we're going to talk about inferior vena cava filters. Okay? And then this is a lot of times where all of my drawings start for whatever reason, and everyone thinks that that looks like a Loch Ness monster or something, but no, it is the heart and the aorta. So I have a question for you guys first to start off. This is on the left side of the body-ish, correct? And what runs then on this side here? Yeah, okay. So this is going to be your inferior vena cava, which is kind of the topic of what we're discussing. This is obviously maybe obvious to some of us, maybe not so obvious to others. This is the aorta, okay? I have a question for you about which leg is more predisposed to getting a deep vein thrombosis, your right leg or your left leg?
Right leg.
Okay, I have a right leg vote.
I would maybe left because the aorta the iliac crosses over the vein.
Good. So the answer to the question is left. So the left side's more predisposed to getting a DVT, even in a normal person, because I always do this as my little thing. So here's your iliac veins. Here's your common iliac veins, right and left. And here's your common iliac arteries, right and left. This happens. So the right iliac artery traverses over the left iliac vein. There's a syndrome. Thanks. We got it. So it's called May-Thurner syndrome. So that's actually when this is causing a significant deep vein thrombosis in the left leg. That's May-Thurner syndrome. Okay, good. So what if someone comes in and they have unilateral swelling of their, say, right leg? How would you work that up? Okay, so you do a physical exam, and so you're looking for swelling, for redness, to rule out like cellulitis. What else would you do? Yeah, check their pulses, okay? What is the thing that's like the classic sign for a DVT? Yeah, so what is it called? Exactly, with the calf. And what's it called? Homan's sign, yeah. So that's like this classic workup for a DVT. Okay. So what would you order? What study? So that's for ABIs are for inflow. So that's the arterial inflow. What would I do to check what we're talking about?
You do a Doppler.
Yeah, so we'd order a venous duplex ultrasound, okay? So say we get the venous duplex ultrasound, and then what if the patient, though, had bilateral lower extremity swelling? What would you maybe be higher up on your differential? If it was bilateral versus unilateral.
Or like
Heart failure, yeah, that's kind of where I was going with that. So what would you get to work that patient up?
Echo.
Yeah, you'd get an echo, okay? So again, just so we're thinking about the patient as a whole, here. Okay, so you order your venous duplex ultrasound, and sure enough, it shows a DVT, a deep vein thrombosis, okay? Uh-oh, the patient also fell in the hospital. What do you know? And now they have a subdural hematoma, since we're on trauma, and this is our lives. Oh, shucks. What do I do now? Can I anticoagulate the patient for their DVT needs anticoagulation? And we always have this discussion where anticoagulation is completely different than DVT prophylaxis, right? That's like my huge thing in the ICU always that everyone seems to never understand. So what do I do now? Yeah, exactly. So that's where this horrible procedure comes in. Not my favorite procedure. Everyone knows that. I despise this procedure for whatever reason. So we have to place an inferior vena cava filter. So what that is literally, it looks like this. It has a little hook on the top, like that, and it literally looks like a little, I don't know, like that. That's what it looks like.
Head scratcher.
Sure, yeah, I don't know. And so there's two approaches. We can do a femoral approach, which is what I like to do, or what's the other one? Yeah, an IJ approach. Which IJ would you go down to deploy this thing?
The right.
The right, because this is a straight shot. So the right IJ is a straight shot down, okay? So that's going to deploy this over here, like this. Now, what are the important vascular structures here that I want to make sure I'm below, and then I make sure I'm above these? So I want to be below what?
Renal veins.
Yeah, the renal veins here, and then I want to be above the bifurcation, because I've also seen this placed here, okay? So what I always do, and it's in my little note that I sent you guys, all of our patients have CT scans. One of my cardiothoracic surgery attendings, before we did anything in residency, I don't care if it was a chest tube, pleuric catheter, trach, or an open thoracotomy, we looked at every single imaging study that was available to us. We take that for granted, okay? So you look at the CT, you look at the different cuts on the CT scan, and you determine exactly where all this is in relationship to what? Yeah, so the vertebral bodies. So typically we end up, let's call it L2 too. Typically we end up right in this vicinity of L3 and L4. Like today we landed right in that sweet spot. It was beautiful. So always review the CT beforehand. Always know how your device works. Make sure you choose the correct device, because I've had the table be open and you're like, that's the jugular one. It's upside down. There's been upside down filters before, okay? So again, there's just a lot of places where this can go wrong. And the other one is you want to look at what's the mnemonic, Ryan, for the orientation of the vessels in the groin?
It's navel.
Yeah. So we talked about this today. So laterally is nerve, artery, vein, empty space, lymphatics. So we're going to use the ultrasound, and we're going to access the vessels here. Then there's a lot of fail-safes. So you access the vessels. You want dark venous, non-pulsatile blood. Then you want to make sure you're on the correct, so the spine is back here. This is where those actually are. And today, we were in the vein, but somehow the wire ended up here, okay? And we knew something wasn't right. So we switched sides, and then we ended up here, and we corrected ourselves because probably went through and through on the stick here. And that's what caused that situation. I've seen complication or issues where this ends up here. Also not good, okay? So a lot of fail-safes, because then once we got where we wanted to do, what did we do? We did one more thing. We shot a venogram. So this is all done under, what's it called? Fluoroscopy, which is like live x-ray, all right? Lots of fail-safes there. And then I told you guys, I gave you a bunch of little tidbits too. Whenever you're putting a wire into a vessel, you make a little skin nick on the wire, and I call this a skin bridge. So you have this little incision, and sometimes the incision doesn't connect to where the wire is entering the skin. You need to make sure you don't have a skin bridge. That's important for this and anything with a Seldinger technique, which is central lines. All sorts of different techniques are coined by Seldinger, was a famous interventional radiologist, kind of the godfather of interventional radiology, where most things we do that are minimally invasive like this, we use a wire, okay? And when you make that incision around that wire, make sure you don't have a little skin bridge. So you do that, you make your incision, and then I said you just take the wire and you kind of just like wiggle it around a little bit, and it gives you an idea. And then also when you're dilating, you want to always dilate as close to the wire and where you're going as possible, not back here, because you're going to kink the wire. And so you dilate a little, and then you jiggle the wire. And then you dilate a little, and then you jiggle the wire. These are great tips for central venous catheter placement too. All right, so that procedure, any procedure, like we said, can go dramatically wrong at any given time. And this is like a good example of that.